Okay, hello, good morning, good afternoon or good evening, wherever you're joining us from. Great to see someone posting there from Malaysia, that's fantastic. Do please post in the chat where you're joining us from, that would be great. So my name is Ben Michael, I'm a clinician scientist and a neurologist, and working with Greta Wood, Viraj Barambi and Kieran Thacker and our colleagues at the Global Health Network. We're delighted to bring you the first of our World Health Organization COVID-19 clinical exchange programs. Our aim, well, in fact, the aim of the WHO when they asked us to do this was really to build on our experience from the pandemic, but provide a platform for clinicians in neurology and allied specialties around the globe to engage with each other about the role that neurologists can play in epidemic and pandemic situations. I'll go on to introduce our guest speaker, who we're delighted to have with us today. Before I do, just a tiny bit of housekeeping. If you could all pop your videos and cameras and mute whilst we get started, but then please do feel free to unmute and turn your cameras on when we move to the breakout rooms. Our focus today is going to be the format of initially a presentation, and then we will break out into 3 breakout rooms where we will discuss the neurological implications of what we've heard and try and address some sort of key clinical epidemiological questions, and then come back and feed back to the group the results of our discussions and close out. Without further ado, it's an absolute pleasure, and we're delighted that Dr. James Sejvar is joining us. Jim trained in neurology at Dartmouth, and then would go on to do his clinical neurological training at the Mayo in Rochester in the US, and then go on to do a fellowship in the Epidemic Intelligence Service for the CDC in the US. And he's now both a neuroepidemiologist working in the high consequence pathogens department of the CDC in the US, and also faculty for neurology at Emory in Georgia, Atlanta. And Jim's going to talk to us today about an emerging problem that he was at the forefront of helping to get to the bottom of. And I think, Jim, it's fair to say a lot of us go into neurology because we like the Sherlock Holmes aspect of trying to work out what's going on. And this is a real case study of the world of a neurologist in the field trying to do exactly that. Thanks, Jim. Over to you.
Great, thank you very much. And let me see. Am I already sharing my slide here?
Not yet.
Not yet. Let me just get. Okay, there we go. Good morning, afternoon, or evening, as has been said. And it's a pleasure to talk to you. Most of these presentations up to this point have been focusing on individual patients, and we're going to take a little bit of a different spin on clinical neurology and talk a little bit about public health and how public health can be applied to neurologic illness. Public health has really been sort of front and center in the news lately with the pandemic. People have been talking to epidemiologists and to public health officials, trying to cover the issues surrounding public health and COVID. But I'm going to talk a little bit about a situation that was brought to our attention at CDC by the Indian Ministry of Health. Now, this happened a couple of years ago and was brought to our attention from the Indian Ministry of Health about a situation in Bihar, which is one of India's poorest states. They had been notified of a strange outbreak of an unexplained neurologic illness characterized by acute onset of seizures and altered mental status. The illness seemed to be affecting children and had been going on since approximately 1995, had been going on for several years. Now, the outbreaks had been variably attributed to Japanese encephalitis, to pesticide exposure, but really the nature of the outbreak really hadn't been explained to this point. And the Ministry of Health was requesting CDC assistance. So just a really quick rundown on epidemiology as a science. It's the science that assesses patterns of disease occurrence in populations and factors that influence these patterns. And neuroepidemiology is simply the application of epidemiologic principles to neurologic disorders. And there are certain factors about neurology that really do necessitate a specific discipline of neuroepidemiology, because there's several features of neurologic disorders that kind of make them challenging to apply traditional epidemiologic methods. So for instance, often neurologic disorders progress and change their clinical characteristics over time, and the accuracy of a particular neurologic diagnosis may be greater at the later stages of an illness. And this can lead to over or underestimation of neurologic illnesses. The actual timing of some neurologic diseases is often not known or very hard to pinpoint, and sometimes this can make the determination of risk factors very difficult. As we know, people with neurologic disorders oftentimes have altered mental status or cognitive disorders, and this can make recollection of risk factors or recollection of the history very difficult. And then many neurologic disorders are syndromes. They're collections of signs and symptoms and not objective diagnostic tests. And this really increases the risk for misclassification. And so for these reasons, neurologic disorders oftentimes are difficult to apply epidemiologic principles to. So the first thing that we did upon arriving to Bihar was to try to simply gather some basic information. Oftentimes, the first approach to an unexplained outbreak of unexplained illness is to see what is going on from the standpoint of the doctors on the ground, or the physicians, the nurses, the caregivers. And we did that by focus group interviews, really kind of asking the doctors, the nurses, the caregivers, what their impression is on the signs, the symptoms, the presentations, the outcomes. And this is done in order to do some hypothesis generating, to really kind of get a sense of what they think is going on and inform our impression of what the sort of the nature of the outbreak is. And the overall objective, or the sort of the tenet of this focus group interviews, is to develop a case definition. And a case definition is just that. It defines what we are going to consider to be a case. And a case definition encompasses the variables of person, place, and time. And this is what really allows you to sort of pinpoint what you're going to be counting, essentially, as a case. And I can't really overemphasize the importance of a good case definition. It's critically important to have a very detailed and good case definition, because that's really going to determine the solidity of the rest of your investigation. And this case definition is then applied to all possible subjects in order to conduct the rest of the investigation. In our situation, we defined a case as the new onset of seizures or altered mental status in the last 7 days in a child less than 15 years of age, excluding simple febrile seizures. And so we took that case definition, we applied it in 2 surveillance sites in 2 tertiary care centers in the city of Muzaffarpur, which is one of the cities in Bihar that had the largest number of cases by report. So the first thing that we did upon developing our case definition is to get some basic demographics. And one of the first things we did was to simply count cases, to really get a sense of the number of cases that we might be dealing with, the age distribution, the sex, those types of variables. And this is simply a histogram, which is basically a plot of the age of cases and the number of people in each age category. And what you can see in this histogram is that there are no cases at 1 year of age. You start to see cases at 2 years, 3, 4, 5, 6 years, up to about 7 years. And then at age 8 and above, the cases seem to disappear. So this histogram really suggests that this is an illness that affects young children. This is what we call an epidemiologic curve. And what this does is this plots the number of cases based upon a date. We plotted this is against the date of admission. It could also be the date of onset, date of death. But what we did was looked at the number of cases against the date of admission. And what you can see is starting in mid-May, there you start to see cases begin to occur. Through late May into early June, you start to see a very rapid increase in the number of cases, peaking in about mid-June. And then in the middle of June, you start to see a very rapid decline in the number of cases to the point where by the end of June and into July, there's very few, if any, cases. And one thing that we did notice that right about here, right in this area, was when the monsoon rains came in Bihar. And so that made us think, there might be something to this in terms of having an influence of the rainy season influencing this epidemiologic curve. But the important thing to note here is that cases appear to increase over a period of time, reach a peak, and then decline rapidly. When we looked at the clinical findings among cases, and at this point we had identified 133 cases. And looking at the clinical findings, what we noticed was there was a really quite high mortality. 45% of those 133 children had a fatal outcome, which is really quite devastating. Nearly all the cases were under the age of 5 years or between the ages of 1 and 5. Per our case definition, nearly all the cases had generalized tonic-clonic seizures at admission. Most of the cases were afebrile. Temperatures were generally less than 99.5 degrees at Fahrenheit at presentation, which is afebrile. Interestingly, we found that the seizure onset in these cases was almost invariably before 8 o'clock in the morning. And we thought again that there might be something to this clinically. Looking at the cerebrospinal fluid, it was mainly bland with CSF with less than 5 white blood cells per cubic millimeter in most cases, less than absence of a peripheral leukocytosis in most cases. And we were able to get a brain MRI in 10 of these cases with and without contrast. And in these cases, there were no focal lesions noted. Now, the other thing that we noted was in a significant number of cases, not a plurality, but a substantial number of children, they had a hypoglycemia, blood glucose less than 70 milligrams per deciliter. So one of the other things, in addition to looking at the demographics and the clinical findings, is to look at exposure histories, to try and find things within the environment that perhaps the children might have been exposed to that might lead to illness. And to do this, we relied on a case control investigation. And a case control investigation is simply an investigation where subjects with the outcome of interest or cases are identified, and the exposure history is then compared with a group called controls who do not have the outcome of interest. And the key here is that cases and controls are basically made as similar as possible based upon various variables. So for instance, age, sex, occupation, and this is done in order to highlight particular risk factors that might result in the disease in some subjects and not others, to really highlight those things that might be leading to disease. And this is known as matching. Now, the end result of this is, among other things, is to develop an odds ratio, which is the number of ill persons known to be exposed to a particular factor compared to the number of non-ill persons known to be exposed to that factor, so that you can kind of get a sense of what risk people are at for a specific exposure. And in the process of a case control study, oftentimes we'll ask pages and pages of questions about various things that cases and controls may have been exposed to, and really try to hone down on those things that appear to be significantly different between the cases and the controls. And this is just a real small snippet of some of the things that we asked in the Bihar investigation to try to get a sense of what might be different between the cases and the controls. And as you can see, we took 101 cases and 202 controls, so 2-to-1 matching, 2 controls for every case, and looked at the matched odds ratio. So we matched these 2 cases to each control and obtained a p-value to look at the significance. And we looked at a number of different variables to see what the odds were that a case and a control were different. And so you can see we asked a number of different things. And so, for instance, when we asked about exposure or visiting an agricultural field, what you can see is both the children's guardian and the children themselves, the cases had an odds ratio of about 3 times that of the controls to be visiting agricultural fields. In other words, the odds that a case would visit an agricultural field were about 3 times that of a control. Now, when we delved into that question a little bit more with a little bit more granularity, we could get into a little bit more specifics about those agricultural exposures. Now, when we asked about exposure to, for instance, vegetable fields, it seemed like the cases and the controls were just about equally likely to have visited vegetable fields. However, when we looked at going to fruit orchards, again, the cases had an odds ratio of about 2.5 times that of the controls for going into to visit the fruit orchards. There were some exposures that seemed to be opposite. In other words, having an exposure seemed to be quote unquote protective from having disease. For instance, children getting water from a village water well had a matched odds ratio of 0.7, which indicates that cases were less likely than controls to develop. Were less likely than controls to visit the well water. We did ask for information on various things that the children consumed as well, trying to get at those types of exposures. And we asked about a various number of various things that they might have eaten, including mangoes, bananas. And in particular, we noticed that lychees appeared to be significant with an odds ratio of about 4. Now, for those of you who may not be familiar with lychees, they're a tropical fruit, a little bit the size of a ping pong ball, that have a very sweet flesh, and they're packed with seeds. They're eaten very commonly in India and throughout South and Southeast Asia. So at this point, I've given you some information on the outbreak and some of the issues that we investigated. There are some questions and some information that I haven't given you to this point in order to sort of foster some discussion during the breakout. But some of the questions that I'd like for people to consider and to think about during the breakout session is, first of all, what does the epidemiologic curve tell you about the nature of the cause of the outbreak? I mentioned the sort of the shape of this epidemiologic curve with the increase and then the sharp decrease. What does that epidemiologic curve seem to tell us about the nature of the outbreak? Secondly, what are the clinical features suggesting to you about the potential cause of the illness? Number 3, what additional questions would you like to explore to further understand the, number 1, the clinical illness, what additional clinical signs and symptoms would you like to know a little bit more about to further define the clinical illness? And then what other information would you like to know to further define the cause of the outbreak? And then lastly, the fourth question would be, what do you make of the results of the case control study? And what other questions regarding the case control study would you like to ask to further try and explore the etiology of the outbreak? And so I think at this point, we'll go ahead and I think then we break up into the breakout groups.
That's great. Yeah, thank you, Jim. That's a great introduction to this sort of emerging problem. If I could ask Adam and the Global Health Network team to put us into our 3 breakout rooms, we'll ping off. Greta, Viraj, Kiran, and myself will staff them to facilitate trying to approach answering these questions, and Jim will be floating between the rooms to help us navigate these questions. Thank you very much. Thanks everyone for engaging with that. I hope your group discussions went well. Certainly ours were really very insightful, and it's really good to have people with really varied backgrounds feeding into opinions and questions and perspectives. It's been really helpful, and particularly to get perspectives from our colleagues working in other countries and continents. That's been really useful. So perhaps, Jim, shall I hand back to you for the grand reveal?
And reveal, sure. So did we? Let me see. Am I sharing my screen still? Let me see. Oops.
Yeah, just coming up now.
Okay. Yeah. So did we want to hear from each group? Do we have time?
Oh, you're quite right. Yes. So we've got a brief. Sorry, you're quite right. Thank you for catching that. So Viraj and Kiran, I'll come to you if that's all right, to let us know the perspectives of your group in a couple of minutes. Thanks. Off you go.
A couple of minutes is going to be difficult, Ben, but I'll do my best. So we've got well, what does the curve tell us? So certainly we had one of the people in our breakout room mentioned that the shape of it felt like it was something very monophasic, that something happens at a particular time point, and then there's this big peak that occurs, and then there's a tail off. We had, I'll move on to the clinical features because, as I said, 2 minutes. We certainly found that it was interesting to look at the fact that there was no fever at all in any of the patients. There was not much of a leukocytosis, and in the vast majority of patients, there was a very bland CSF. Also interesting that hypoglycemia was so prevalent. And the thing that jumped out at us was also that obviously very young children coming in with seizures, but interesting was the time of the seizures. The seizures very early in the morning, and we wonder whether that told us anything about what was affecting that area. What additional questions would you like to explore to further understand the illness? Well, we had many questions, but I'll try and go through them. We wanted to ask when do lychees ripen in the area? Certainly, Eric, one of the people in our group, had mentioned that when he thought of hypoglycemia in young children, he knew that unripe ackee fruit can often cause hypoglycemia, and he wondered whether lychees did a similar thing. Then we also have, was there any clear external catastrophe that we haven't been told about? This monophasic curve, does it indicate that something happened just before in the weeks or the days leading up to the start of that curve? We also wondered what had the patients, the cases, had they eaten anything specifically the night before or the morning before that may have caused symptoms? How many seizures happened before the presentation, and how prolonged were they? Because that might help explain some of those cases where there was a little bit of a sort of high white cell count in the CSF. So, most of them were less than 5, but some were above. And then thinking a bit wider, we wanted to know about whether there was Plasmodium falciparum present in the area, and if so, the blood films might be useful in explaining what's happening. The Japanese encephalitis vaccine status in the area. We wondered whether the siblings of the cases had been investigated at all, because that might tell us something either about genetic preponderance or also about sort of exposure to any other environmental factor that the siblings had also been exposed to or not exposed to in that case. And then I think that's quite a lot, isn't it? I've said quite a bit. I'll stop there. I'll let some of the other breakout rooms add bits to it.
That's great. Thanks, Viraj, and an okay from Dr. Sejvar, so that's good. Greta, do you want to feedback your team, please?
Yes, absolutely. So I think we echoed a lot of the points that Viraj's group had made. I think when we first looked at the curve, the initial comment was, is this vector-borne? Because I think with a lot of these seasonal illnesses are vector-borne, but I think then when we looked at the very abrupt onset and the abrupt kind of closure of the outbreak, that wasn't typical. There weren't, it seemed just quick start and quick finish, which kind of went against that hypothesis. And then as we looked at the clinical features, I think particularly the lack of fever and the hypoglycemia became kind of increasingly convinced that this might not be infectious. And there were questions around the occupation. So particularly, did the parents of the children have particular occupations? And about the development, the fact that this was mainly very young children, was there something about their development that might have put them at risk? And so those were our sort of additional comments on top of what we've seen in the other groups. Thank you.
That's great, Greta, thank you. And I'll briefly feedback from our group as well. Again, a lot of the same discussions, but some additional things. I think we've, as a team, felt that it might be more likely to be infectious. We thought there was something about children being dirty. There might be some hygiene issues, and whether there was some sort of diarrheal type illness that was being transmitted between children in this community, whether it related to them all gathering together for the harvest, and also with this issue with the water source perhaps being protective. We wondered that perhaps they were getting their water from an unclean source and then spreading it between the children themselves when they gathered for the harvest period. That's everything from us. Jim, I'll hand to you. Thank you.
So, yeah, I'm going to put out a recruiting notice to all you guys for Centers for Disease Control. You guys are spot on for a lot of these things. I'm just going to go really quickly because I know we're running low on time, but the people that commented on the epidemiologic curve, exactly right. The epidemiologic curve is monophasic, and it would suggest predominantly a single point source exposure with a rapid endpoint, or an exposure to an infectious agent with one incubation period. With those people that sort of mentioned about a non-infectious etiology, I think we're spot on. In that, the absence of a fever in most, the lack of CSF pleocytosis, the lack of peripheral leukocytosis, no abnormalities in neuroimaging, all of that, really kind of suggests that this is not Japanese encephalitis or some sort of an infectious etiology. The presence of the hypoglycemia, however, really suggested to us that that was a key to the etiology. One of the things that I didn't mention to you guys is we did a number of exploratory investigations for various viral, bacterial, parasitic, rickettsial pathogens, and all of these things basically came up negative, including next generation or deep sequencing for appropriately timed specimens. One of the things that I also didn't mention is that this is a very, very poor area, and that most of these children were noted to be wasted, which is being low weight for height and is a marker of acute malnutrition, and stunted, which is low height for age and is a marker of chronic malnutrition. And so even a slight episode of hypoglycemia is likely to really affect and impact these children very significantly. So fundamentally, epidemiologically, from the case control study, exposure to or eating lychees appeared to be associated with being a case. And this is something we really focused on. So first off, this area in Bihar is a lychee cultivation area. In fact, it was one of the sort of the prime areas where lychees were grown in India. Temporarily, that May, June, early July period corresponded with the lychee harvesting season. And as we saw in the case control investigation, it appeared that lychee eating appeared to be significantly associated with the illness. And so I think it was Eric Schmutzart who really kind of nailed it here. There was biological plausibility in having lychees being associated with the illness, with hypoglycemic seizures, basically. There is what's called a toxic hypoglycemic syndrome seen in the West Indies due to hypoglycin A toxin in what's called ackee fruit, where this toxin inhibits gluconeogenesis, leading to acute hypoglycemia. And both ackee and lychee fruits are both in the Sapondaceae family. And so when we took lychees from this area and run mass spectrophotometry on them, we did identify a compound called methylene cyclopropylglycine, or MCPG, in the lychee seeds, which is basically a homologue to hypoglycin A. And this was found to be a potent hypoglycemic toxin. So really the timeline that we really kind of sort of outlined was that these are children who started off as being malnourished and acutely malnourished to begin with, were exposed to lychees in the field during the harvesting season. These children were picking up lychees off the ground that had fallen and biting into the lychee, and oftentimes biting into all the seeds that are in the lychees and ingesting this MCPG, or the hypoglycin. This MCPG was resulting in acute hypoglycemia, and this was predominantly happening in the early morning hours after a prolonged period of fasting. This acute hypoglycemia was then resulting in the acute onset of symptomatic hypoglycemic seizures. And these seizures could then basically be remedied by the rapid administration and infusion of glucose. So, we were able to kind of sort of trace out this pathway or this timeline. And really, once we started providing glucometers and stressing the importance of rapid administration of glucose to these children, we were able to cut the mortality from this particular syndrome down to nearly zero. And so our recommendations from after the outbreak response in terms of preventing illness was to minimize the consumption of lychee fruit, particularly in young children who weren't able to decipher between the pulp of the fruit and the seeds, and to ensure that the children receive an evening meal to reduce the chance of nighttime fasting hypoglycemia. And then in terms of reducing the mortality, it was to increase the community awareness about symptoms and treatment in terms of, really stressing getting these children a meal in the evening hours, and then providing glucometers and training to health staff at the first point of contact for rapid glucose assessment and correction. And really, this is one of those rewarding situations in public health where you really were able to make a dramatic difference in terms of mortality with a very simple intervention. And so I really want to commend everybody in the working groups. You guys really, made some really, really astute observations and really, really thought of some really good questions on this. So congratulations.
That's brilliant. Thanks, Jim. And we should all thank you, not just for your presentation, for all the important work that you and your team do. I think this is a great example of how neurologists can play a role in clinical epidemiological research when particularly de novo seizures and other severe acute neurological presentations start to come to the fore in a particular region. And I think it's a great demonstration of how applying relatively simple approaches to really understanding the clinical features and the environmental risk factors in these case control studies that you describe, and how informed by these data, actually relatively, you could call them simple, but I suppose pragmatic at least, interventions can be important for both preventing the onset of this condition and also the early diagnosis and treatment of a reversible cause of what could otherwise be a potentially incredibly severe problem. So,
there's Oh,
Sorry, Jim.
sorry. Oh no, I was just going to say. I mean, you know, for years, the focus had been on administration of anti-epileptics and controlling for vectors and whatnot to no success. And it was just a simple recognition of hypoglycemia and provision of glucose that was able to really change the tide here. So.
Yeah, that's brilliant. And it's, of course, important for BIHAR, but translatable to problems, globally and emerging problems. And it's not always infection.
Right.
With that, I'd just like to close by particularly thanking Greta, Kieran and Viraj for getting us all organised, particularly Greta, who does all the hard work, and our colleagues at the Global Health Network for hosting us. We'll be joining again in January for the next of these monthly WHO sessions. And finally, just a huge thanks to James Sejvar for all the work he does and for walking us through a really great presentation. Thanks, everyone.